Welcome to Section 4 of Cardiovascular Anatomy. In this section, we will discuss the venous supply of the lower part of the body. This table lists the important veins to be familiar with when it comes to the lower limbs. This includes the internal pudendal veins, the inferior rectal veins, the vertebral venous plexus, the femoral vein, the right saphenous vein, and the superficial epigastric vein. Let's start by discussing the internal pudendal veins. This image demonstrates the veins of the lower limbs and can be found in Section 4 of your cardiovascular anatomy text. We can see that the inferior vena cava bifurcates into the common iliac veins. It then splits into the internal iliac vein and the external iliac vein. You can see that on both sides. And we can see the internal iliac vein labeled right here. Branching from the internal iliac veins are the internal pudendal veins, which is labeled right here. And you can see that extending from the internal iliac and coming down. From there, you can also see a venous plexus to the prostate, the vulva, and the penis. And you can also see branching from the internal pudendal vein, the inferior rectal veins. Now going back to this venous plexus, it's important to remember that these components each have their own named veins or venous plexuses, such as the prostatic venous plexus. However, the important thing to remember is that all of these structures drain into the internal pudendal venous plexus, which then drains into the internal iliac veins. This means you shouldn't get wrapped up in the specific names of the veins related to the prostate, vulva, and penis. Just recognize that there's a venous plexus to these, and that drains into the internal pudendal, which drains into the internal iliac. Going back to the table, we can see the internal pudendal vein empties into the internal iliac veins. And it has a plexus that drains the prostate, vulva, and penis, and it also has the inferior rectal vein, which drains the inferior portion of the rectum. And this brings us to the next point, the inferior rectal veins. These veins drain the rectum below the pectinate line. And since they are located below the pectinate line, they are external and receive somatic innervation, which means when hemorrhoids occur, they are painful. Once again, these are located right here. These veins are also significant because in portal hypertension, the superior rectal veins can have such high pressure that the inferior rectal veins become engorged. Before we talk about this idea more, I just want to point out that the internal iliac vein also gives rise to the middle rectal veins. But don't worry about the middle rectal veins, just think of the inferior rectal veins. If you can keep track of the superior rectal veins and the inferior rectal veins, then you'll be in good shape. This image depicts the venous supply of the GI system, including the portal network. It is discussed in more detail in Section 6 of Cardiovascular Anatomy. You can see here that the superior rectal veins supplies the superior portion of the rectum, where the inferior rectal vein supplies the inferior portion. Now, when there's cirrhosis of the liver, there's high pressure in the portal network, which is all through here. And part of the portal network is the inferior mesenteric vein. So this pressure will be high here, which means there will be high pressure in the superior rectal vein. And this causes the anal rectal varices that can occur in patients with liver cirrhosis. Now, the superior rectal vein can also be the source of hemorrhoids, but these occur above the pectinate line, so they receive visceral innervation, which means they are painless, whereas hemorrhoids in the inferior rectal veins receive somatic innervation, so they're painful. Going back to the table, the inferior rectal veins drain the rectum below the pectinate line. They cause external and therefore painful hemorrhoids, and they can form anal rectal varices in patients with cirrhosis. And this is because the inferior rectal veins form an anastomosis with the superior rectal veins. Now let's talk about the vertebral venous plexus. The vertebral venous plexus drains the vertebral bodies of the spinal column, and it communicates with the internal iliac veins. You can see the vertebral venous plexus right here, and it drains the vertebral bodies of the spine and communicates with the internal iliac vein, as just mentioned. The fact that it communicates with the internal iliac vein is very significant because it means that it's indirectly connected to the prostate, vulva, and penis. Therefore, cancers in these lower regions can impact the vertebral bodies. For example, prostate cancer can metastasize and travel through the internal pudendal vein, and then to the internal iliac vein, and then to the vertebral venous plexus. So the spinal column can have metastases. A classic scenario is an older man presenting with low back pain and urinary symptoms suggesting prostate cancer. The patient gets a lumbar x-ray and it reveals metastases in the spine. And these metastases traveled from the prostate to the vertebral venous plexus, as we just discussed. Now, as written here, the vertebral venous plexus communicates with the internal iliac veins, so branches of the internal iliac vein can facilitate metastases or cancers from the pelvis, which can then seed the vertebral bodies. Now let's talk about the femoral vein. Going back to this image, we see the external iliac vein becomes the femoral vein at the level of the inguinal ligament. just like in the arterial system. So the external iliac comes down and becomes the femoral vein, which is labeled over here. Now, as the femoral vein progresses downward, it almost reaches the knee. This is very important. To better understand, let's jump down to the foot. So here's a quick sketch of the foot. Nearly everything from the foot and up drains into the popliteal vein. So you have all these veins draining ultimately into the popliteal vein. And the popliteal vein is located behind the knee in the popliteal fossa. And as the popliteal vein ascends, it will actually cross the adductor magnus muscle in the distal part of the femur. And when the popliteal vein crosses the adductor magnus muscle, it becomes the femoral vein. So going from the top again, we have the femoral vein, which goes down, and it ultimately becomes the popliteal vein, which drains the whole foot. Now this is very important to remember because these are deep veins. The femoral vein and the popliteal vein are deep. Therefore, they can be the site of deep vein thromboses, or DVTs. However, the great saphenous vein, which branches from the femoral vein, as you can see here, is superficial, so it can be the site of superficial venous thromboses. Now, the great saphenous vein is very long and travels nearly the entire length of the leg on the medial side, and it ultimately drains into the femoral vein, as we've shown here, but it's still superficial. Now, the location where the great saphenous vein drains into the femoral vein is very high yield. This is the femoral triangle. We will talk more about the femoral triangle in a moment. One of the reasons that the great saphenous vein is a high yield vein to understand and know is because clinically it can be used in vascular operations, such as a vascular graft. Now, why would the great saphenous vein be such an ideal vein to use in cardiac grafts? Well, it's superficial, so it's easy to get, and it's moderate in diameter, and it doesn't drain all the deep structures that the popliteal and femoral veins do, which means it's not necessary for all these deep structures to get rid of their deoxygenated blood. Going back to the table, we see that the popliteal vein becomes the femoral vein at the adductor hiatus, or the adductor magnus, as we discussed on the previous slide. And because the femoral vein and the popliteal veins are deep, they can be the site of deep vein thromboses. Another clinical note regarding the femoral vein is that it is a common site for central venous line insertion. Also, the femoral vein drains the great saphenous vein, which we've labeled down here, and the great saphenous vein drains into the femoral vein at the level of the femoral triangle. It's superficial, so it can be the site of superficial venous thromboses, and because it's superficial and it's moderate in diameter, it's good for cardiac grafts. Going back up to the femoral vein box, we can see that it also drains the superficial epigastric vein, which brings us to this last point. The superficial epigastric veins are labeled right here. You can see that on both sides. These drain the superficial abdominal wall below the umbilicus into the femoral vein. In portal hypertension, the paraumbilical veins recanalize and form a high-pressure anastomosis with these superficial epigastric veins. So all of this portal hypertension leads to increased pressure and causes caput medusae. And this is simply the paraumbilical varices that you can see in cirrhotic patients. And of course, this would be seen around the umbilicus. So once again, the superficial epigastric vein drains the superficial abdominal wall, and it can cause caput medusae in portal hypertension, and that's because it forms an anastomosis with the paraumbilical veins. Okay, now that we covered all the material in this table, let's dive into the femoral triangle I mentioned before. Now I have written the three borders here. The femoral triangle is formed by the sartorius, which is the lateral border, the adductor longus, which is the medial border, and the inguinal ligament, which is the superior border. And within the triangle, there are three important structures to remember. The femoral nerve, and this is the most lateral one, the femoral artery, which is in the middle, and the femoral vein, which is the most medial component. Now the memory hook to remember all of this is swords for naval cadets. Swords because it sounds like sartorius, and naval because NAV helps you remember nerve, artery, and vein. And for cadets, I want you to focus on the A and D for adductor longus. So from lateral to medial, we have swords for naval cadets. Now this image depicts the femoral triangle and can be found in section 4 of your cardiovascular anatomy text. And we can see the superior border right here, the inguinal ligament, and then we have the sartorius, which is the lateral border, and then we have the adductor longus muscle, which forms the medial border. And while we're here, just know that the inguinal ligament attaches to the pubic tubercle. As mentioned before, there are three important structures within the femoral triangle: the femoral nerve, the femoral artery, and the femoral vein. And you go in that order from left to right. And keeping all of this straight is really important. So again, swords for naval cadets. So swords for sartorius, which is the most lateral, then the femoral nerve, artery, and vein, which we've demonstrated. And that brings us to the most medial portion, which is the adductor longus. Swords for naval cadets. Now let's do some questions to apply what you've learned. A 45-year-old man with a long history of intermittent and painful hemorrhoids presents to clinic and reports bright red blood per rectum. A rectal exam is performed, which confirms the presence of a hemorrhoid. The vein responsible for this eventually drains into which of the following structures: the great saphenous vein, the femoral vein, the external iliac vein, or the internal iliac vein. Now, hopefully you noticed that this man has painful hemorrhoids. Since it is painful, you should be thinking of an external hemorrhoid, which is supplied by the inferior rectal vein. And from what does the inferior rectal vein branch? It comes from the internopudendal vein, which of course branched from the internal iliac vein. So the answer to our question is D. Going back to this image, we can clearly see that the inferior rectal veins drain into the internopudendal veins, which drain into the internal iliac veins. So obviously the inferior rectal veins don't directly drain into the internal iliac veins, but they do ultimately. So given the options, only D makes sense. Now let's do one last question. A 65-year-old woman is about to undergo a coronary artery bypass graft, or CABG. The surgeon intends to use the great saphenous vein to create the bypass. During the operation, the surgeon identifies the vessel the target vein drains into. What muscle lies medial to this juncture, and what major nerve is lateral to this juncture? Hopefully you noticed that the surgeon identified the femoral vein, because the target vein is the great saphenous vein, and he identified the vessel that the target vein drains into, which is the femoral vein. So now that we've identified the femoral vein, we can answer the first question. What muscle lies medial to this juncture? So the question is really asking what muscle forms the medial border of the femoral triangle. And if you remember swords for naval cadets, you can quickly identify the femoral vein, and what would be medial to that? The adductor longus. And what nerve is lateral to this juncture? You can see that that should be the femoral nerve. So we started with the femoral vein, and we identified the adductor longus, which would be the medial border muscle, and the major nerve that is lateral to the femoral vein would be the femoral nerve, which is right here, which answers our questions. And that concludes this section.